Familiarity with malignant lesions of the head and neck is essential for physicians to be able to distinguish life-threatening masses from those of little consequence, choose appropriate therapy, and avoid injudicious surgery. Primary malignant neoplasms of the head and neck, excluding skin cancer, account for 5% of new cancers each year in the United States. The male-female ratio is 3:1 to 4:1, and most lesions occur in patients older than 40 years of age. Approximately 80% of primary head and neck malignancies are squamous cell carcinomas. The remainder are thyroid cancers, salivary neoplasms, lymphoma, and other less common tumors. The percentage of patients with a second primary malignancy at the time of initial presentation has been reported to be as high as 17%. Tobacco use, chewing or smoking, alcohol consumption, and exposure to radiation are etiologic factors in most squamous cell carcinomas of the head and neck. Approximately 85% of patients with head or neck cancer smoke or formerly smoked cigarettes at the time of diagnosis. Evaluation of the patient starts with a thorough history and physical examination. The patient should be questioned about exposure to etiologic agents, for example, tobacco, alcohol, sawdust, other toxins, and irradiation. Symptoms associated with diagnosis of cancer include hoarseness or sore throat of more than 3 weeks duration, dysphagia, dyspnea, non-healing ulcers, hemoptysis, and neck mass. A familial history of head or neck malignancy should also be obtained. The patient's nutritional status is of prime concern when choosing therapy. The family history is critical in some head and neck tumors with inherited factors, for example, medullary thyroid cancer. Many patients are malnourished, either because of alcoholism or because of an obstructive tumor. The physical examination must include an inspection of all the skin and mucosal surfaces of the head and neck. An intranasal examination and indirect mirror examination of the nasopharynx and hypopharynx are included. Careful palpation of the oral cavity, base of the tongue, and oropharynx is mandatory. Fiber optic examination of the nose, pharynx, and larynx is indicated in all patients who are being evaluated for head and neck cancer. Treatment is based on the site and pathology of the primary cancer and the extent of the local, regional, and distant disease. Surgery is indicated treatment for many patients with head and neck cancer. The choice of surgery can be influenced by many factors. The time for surgical intervention is short, and careful pathologic examination of the tissue removed is possible. In addition, the effects of radiation are avoided, and radiation can be saved for recurrent disease or other primary cancers. Malnourishment secondary to dysphagia due to the tumor location can increase the perioperative risk of morbidity and mortality. Treatment is sometimes delayed or limited because of the need for hyperalimentation. In most patients, this requirement can be met with nutritional supplements or tube feedings into the stomach, but parenteral nutrition is sometimes required. The patient may have a coexistent systemic disease, for example, diabetes, chronic obstructive pulmonary disease, thyroid disease, and/or coronary artery disease, which increases the surgical risk. The necessary surgical procedures of the larynx, tongue, oropharynx, hypopharynx, and mandible can alter or prevent swallowing and the ability to communicate. This type of surgery is best performed at institutions that can provide the full range of oncologic rehabilitative services. Surgery for a cure is generally not indicated in patients with distant metastases. Radiation therapy alone is adequate treatment for many early lesions. Radiation can provide a cure without the functional or cosmetic deficits associated with surgery, treat multiple primary lesions simultaneously, and it can prophylactically treat regional nodes that are clinically negative. Planned postoperative radiation can significantly increase the survival rate for patients with advanced lesions. Recent studies show that the response to radiation therapy can be enhanced, even in advanced tumors, by using hyperfractionation, more than one daily treatment, and concomitant chemotherapy. However, these techniques increase the risk and severity of local side effects. Complications of radiotherapy include mucositis, xerostomia, loss of taste, dermal and soft tissue fibrosis, dental caries, and bone and soft tissue necrosis. A dental examination is required before radiotherapy. Dental treatment during and up to 2 years after radiotherapy can be hazardous because of decreased vascularity and consequent delayed healing. Chemotherapy is not curative as a single treatment modality in head and neck squamous cell carcinoma. Cisplatin is the most effective agent. It is often combined with 5-fluorouracil, 5-FU, paclitaxel, Taxol, and other drugs. Methotrexate is also an effective single agent and is used primarily for palliation. Chemotherapy is used in neoadjuvant treatment to reduce the tumor burden before radiation or surgery. Chemotherapy is used with concomitant radiation therapy to increase response rates in advanced tumors. Chemotherapy is being evaluated as adjuvant therapy to reduce recurrence rates. Chemotherapy is used for palliation in patients with unresectable tumors or distant metastases. Rehabilitation should be planned at the same time as treatment. Cosmetic and functional defects are reconstructed at the time of the cancer resection whenever possible. The use of surgical flaps has greatly facilitated reconstruction. The flaps may be local flaps, nasolabial, forehead, distant pedicled skin flaps, deltopectoral, omocervical, pedicled myocutaneous flaps, pectoralis major, latissimus dorsi, trapezius, or free microvascular flaps. Prosthetic rehabilitation is necessary when portions of the maxilla, orbit, mandible, or palate are resected. When the larynx is removed, intensive rehabilitation is required to re-establish the voice. Initially, patients are taught to speak with an electrolarynx that is applied to the neck surface and positioned intraorally or incorporated within dentures. Later, patients learn to speak with regurgitated air, esophageal speech, or with a prosthesis, a one-way valve placed in a surgically created tracheoesophageal fistula. Many patients who undergo partial laryngectomy, pharyngectomy, or glossectomy require training to facilitate swallowing and to avoid aspiration. The neck is divided into anterior and posterior triangles. The anterior triangle is bounded by the midline of the neck, the inferior border of the mandible, and the anterior border of the sternocleidomastoid muscle. It can be subdivided further into submandibular, submental, superior carotid, and inferior carotid triangles. The posterior triangle is bounded by the posterior border of the sternocleidomastoid muscle, the anterior border of the trapezius, and the clavicle. It is divided further into supraclavicular and occipital triangles. Facial planes of the neck enclose the lymphatic system. The superficial fascia is subcutaneous and envelops the platysmal. The deep fascia has three parts: A, superficial layer, which invests the sternocleidomastoid and trapezius muscles; B, pretracheal fascia, middle; and C, prevertebral fascia, deep. Lymph nodes on each side of the neck number approximately 75. Most of them lie within the deep jugular and spinal accessory chains. The jugular chain is divided into superior, middle, and inferior groups. There are 6 cervical lymph node levels. Level 1 contains the submental and submandibular nodes. Level 2 is the upper third of the jugular nodes medial to the sternocleidomastoid muscle, and its inferior boundary is the plane of the hyoid bone, clinical, of the bifurcation of the carotid artery, surgical. Level 3 describes the middle jugular nodes and is bounded inferiorly by the plane of the cricoid cartilage, clinical, or the omohyoid, surgical. Level 4 is defined superiorly by the omohyoid muscle and inferiorly the clavicle. Level 5 contains the posterior cervical triangle nodes, and Level 6 contains the paratracheal and pretracheal nodes. Workup for malignancy should be undertaken in all adults with a persistent neck mass. A careful history and physical examination is taken, and the head and neck are examined for evidence of a possible primary cancer. If the primary cancer is not identified on the initial examination, the workup that follows should include a chest X-ray, barium swallow, and CT scan of the neck are indicated in most patients. MRI of the neck and other X-ray or nuclear medicine studies are guided by findings on the history and physical examination. MRI is particularly useful in defining deeply invasive tumors of the tongue, pharynx, and larynx. CT of the sinuses can be used to search for primary tumors. CT or MRI of the chest and abdomen are often used for staging. Panendoscopy, direct laryngoscopy, esophagoscopy, bronchoscopy, and nasopharyngoscopy are performed routinely to evaluate patients with a neck mass suspect of being malignant in order to identify the site of primary pathology. If the result of the endoscopic survey is negative, random biopsies of the nasopharynx, right, middle, and left, are performed. A random biopsy of the tongue base or a tonsillectomy may also be worthwhile. If all biopsies have negative results, the next step is to proceed a fine needle aspirate. If that is negative or inconclusive, open neck biopsy and frozen section should be performed as the last resort. Once a biopsy has been interpreted, staging can be done. Stage N0, no clinically positive node. Stage N1, a single clinically positive node homolateral to the primary tumor and 3 centimeters or less in its greatest diameter. Stage N2A, a single clinically positive homolateral node larger than 3 centimeters but less than 6 centimeters in its greatest diameter. Stage N2B, multiple clinically positive homolateral nodes with none larger than 6 centimeters in its greatest diameter. Stage N2C, bilateral or contralateral clinically positive nodes with none larger than 6 centimeters in its greatest diameter. Stage N3, any node greater than 6 centimeters in greatest diameter. If a primary cancer is identified and confirmed with biopsy, the metastatic neck disease is treated in conjunction with this primary cancer. Radical neck dissection is an en-bloc dissection of the cervical lymphatics. It includes removal of the sternocleidomastoid muscle, internal jugular vein, or spinal accessory nerve. It is performed when squamous cell carcinoma is found in a neck mass with an unknown primary cancer or in conjunction with excision of the primary tumor. Modified, functional, conservative neck dissection removes the cervical lymphatics within their facial compartments. It spares the sternocleidomastoid muscle, internal jugular vein, and spinal accessory nerve. Indications for use include elective neck dissections, a single node less than 3 centimeters in diameter that is to be treated postoperatively with radiation, differentiated thyroid cancers with neck metastases, and simultaneous bilateral neck dissections. Segmental neck dissection refers to the removal of less than all 5 nodal groups on one side of the neck. For example, submandibular triangle dissection, supraomohyoid dissection. Elective neck dissection refers to surgical treatment of N0 disease. There is controversy about when and whether to use elective neck dissection because radiation therapy can provide prophylaxis for metastatic neck disease in many cases. The choice between surgery and radiation usually depends on the treatment of the primary tumor. In general, when elective neck dissection is performed, it is done for a primary cancer that has a 30% or greater chance of occult metastasis. All sinuses are paired, and all are contiguous with the nasal cavity through their natural ostia. The nose and sinuses are lined with a respiratory mucosa, which is pseudostratified columnar with goblet cells and cilia. Lymphatic drainage is through the parapharyngeal or retropharyngeal nodes. Secondary lymphatics are the subdigastric nodes, the internal jugular chain. Most tumors, 59%, are in the maxillary sinus, 24% are in the nasal cavity, 16% in the ethmoid sinuses, and 1% in the frontal and sphenoid sinuses. Approximately 80% of the malignancies are squamous cell carcinoma. Tumors that arise anteriorly tend to be well differentiated. Tumors arising from the posterior nasal cavity and ethmoids are generally poorly differentiated. Nasal and sinus cancers are locally invasive. Nodal metastases are unusual and tend to occur late, even with extensive local disease. Approximately 10 to 14% of the malignancies are adenocarcinomas, including adenoid cystic carcinoma. Inverted papilloma is a benign tumor. The reported incidence of malignant degeneration is approximately 2%. The incidence of associated malignancy in adjacent tissue is as high as 15%. Presenting symptoms can include nasal obstruction, epistaxis, localized pain, tooth pain, cranial nerve deficits, a mass in the face, palate, or maxillary alveolus, proptosis, and trismus. The extent of the disease is determined by physical examination and radiographic studies. A CT scan is useful for identifying bony erosions and orbital or intracranial extension. MRI can be used to determine intraorbital and intracranial invasion. Arteriography is useful in patients with skull base invasion or rare vascular tumors. Most biopsies can be performed under local anesthesia. Staging is available for maxillary sinus cancer. Stage T1 and T2 maxillary sinus tumors are treated with subtotal or radical maxillectomy. Radiation is used when cancer may have been left at the surgical margins and when tumors recur. Stage T3 and T4 tumors receive radiotherapy followed by reevaluation for surgical resection. Orbital exenteration and skin resection are performed when necessary. Ethmoid sinus or nasal cavity tumors are usually treated with radiation therapy followed by surgery for residual disease. Extensive cancers are treated with combined craniofacial resection for selected patients. Chemotherapy is often utilized either in conjunction with surgery and radiation or for palliation. Inverted papillomas are treated by en-bloc resection that includes the lateral nasal wall and ethmoid sinus. Cervical lymph node metastases are treated with radiotherapy followed by radical neck dissection for residual disease. The overall cure rate is approximately 30 to 35%. The 5-year survival rate for patients with stage T1 and T2 lesions is 70%. The 5-year survival rate for patients with stage T3 and T4 lesions is 15 to 20%. The nasopharynx is the most cephalad portion of the pharynx. Its roof is formed by the basio-occipital and sphenoid bones, and its posterior wall is formed by the atlas. These walls are covered by mucosa, and the adenoid tissue is embedded within. The lateral wall contains the orifice of the eustachian tube, and just posterior to that, the fossa of Rosenmuller. The choanae define the anterior limit, and the free edge of the soft palate provides the inferior limit. Lymphatic drainage is to the lateral retropharyngeal, jugulodigastric, tonsillar, and high spinal accessory nodes. Nasopharyngeal cancer has a high incidence among people from the Guangdong province of China. Elevated Epstein-Barr virus titer has a high incidence among persons with cancer of the nasopharynx. Nasopharyngeal cancer occurs at younger ages than do most solid head and neck tumors. Approximately 85% of nasopharyngeal tumors are epithelial. 7.5% are lymphomas. Epithelial tumors commonly arise in the fossa of Rosenmuller. Presenting symptoms are anterior or posterior epistaxis, cervical adenopathy, serous otitis media, and nasal obstruction. Headache, diplopia, facial numbness, trismus, ptosis, and hoarseness may also be present. At presentation, 60 to 70% of patients will have nodal disease, and 38% will have cranial nerve involvement. Diagnosis is confirmed by endoscopic biopsy or by biopsy if a metastatic lymph node. Nasopharyngeal cancer can best be staged and monitored with CT and MRI scan. When a patient presents with an elevated Epstein-Barr virus titer, monitoring of the titer should show a decrease with successful treatment and an increase with recurrences. Treatment of all epithelial nasopharyngeal tumors is radiation. The dose, usually 65 to 75 gray, is delivered to the nasopharynx and to both sides of the neck. Improved responses are possible with combined chemotherapy and radiation in patients who can tolerate the increased toxicity. Radical neck dissection is performed for residual nodes if the primary tumor is controlled. The 5-year survival rate is 40% in patients without positive nodes and 20% in patients with positive nodes. The oral cavity extends from the lip anteriorly to the fossal arches posteriorly. It includes the lips, the buccal mucosa, the gingiva, the retromolar trigons, the hard palate, the anterior 2/3 of the tongue, the oral tongue, and the floor of the mouth. Lymphatic drainage is to the submental, submandibular, and deep jugular nodes. Approximately 90% of patients that develop cancers of the oral cavity are heavy users of tobacco, either smoking or chewing. 80% of patients are heavy drinkers of alcohol. Syphilis accounts for a few cases, and herpes simplex virus type 1 is currently under investigation as a cause. Presenting symptoms can include loose teeth, painful or non-healing ulcers, odynophagia, otalgia with posterior lesions, and cervical adenopathy. The lip is the most common site of oral cavity carcinoma, followed by the oral tongue and the floor of the mouth. Mandibular radiographs should be taken to assess the bony involvement by adjacent tumors. Pain, which is often a late symptom, occurs after ulceration develops. Nodal metastases, up to 30% of which are occult, microscopic metastatic disease, are found in 50% of patients with squamous cell carcinoma of the anterior tongue and in 58% of patients with cancer of the floor of the mouth, occult metastases in up to 12% of the patients. Metastases are uncommon and usually occur late in cancer of the lip or the buccal mucosa. Once a biopsy has been interpreted, staging and treatment can begin. Staging. Stage T1. Tumor is less than 2 centimeters in its greatest diameter. Stage T2. Tumor is 2 to 4 centimeters in its greatest diameter. Stage T3. Tumor is more than 4 centimeters in its greatest diameter. Stage T4. Tumor is massive and involves the mandible, pterygoid muscles, antrum, root of the tongue, or skin. Treatment. Stage T1. NO tumors can be treated with either local excision or radiotherapy. Stage T2. Larger lesions should be treated with combined surgery and radiation. Surgery involves an en-bloc resection of the tumor and radical neck dissection. Stage T3. Either a partial mandibulectomy is included, or the tumor is pulled through medially to the mandible into the neck. That is, the tumor is removed en bloc with the radical neck specimen, leaving the mandible intact. Tumors attached to the mandible may be removed with a partial thickness of mandible, that is, the lingual plate or alveolar process. The mandibular arch is kept intact when possible. Stage T4. Tumors demonstrating bony erosion in the mandible are removed with a full thickness portion of bone. The overall 5-year survival rate for cancer of all oral cavity sites is approximately 65%. For lip cancer, 5-year survival rates as high as 90% have been reported. The prognosis for tongue lesions is worse if the lesion is posterior. Because anterior, mobile tongue lesions are often diagnosed when they are small, the overall 5-year survival rate is higher than 65%. Posterior, tongue-based lesions are often stage 3 or stage 4 at diagnosis, and the overall 5-year survival rate is less than 40%. Posterior lesions involving the tongue base can invade the preepiglottic space, necessitating laryngectomy. The oropharynx is bounded by the free edge of the soft palate superiorly, the tip of the epiglottis inferiorly, and the anterior tonsillar pillar anteriorly. The oropharynx contains the soft palate, the tonsillar fossae and fossal tonsils, the lateral and posterior pharyngeal walls, and the base of the tongue. The parapharyngeal space is directly lateral to the oropharynx. It contains the glossopharyngeal, lingual, and inferior alveolar nerves, the pterygoid muscles, the internal maxillary artery, and the carotid sheath. It is a site of early extension of an oropharyngeal tumor. It also provides a pathway for the tumor to spread to the base of the skull. Lymphatic drainage is primarily to the jugulo-digastric tonsillar nodes. Tumors of the soft palate, lateral wall, and tongue base also spread to the retropharyngeal and parapharyngeal nodes. Retromolar trigon lesions can drain to submaxillary nodes. Alcohol and tobacco use are commonly found together in patients with oropharyngeal cancer. There appears to be a synergistic effect between the two substances, but it has not been defined. Local mucosal irritation, malnutrition, and immune defects have also been implicated. The most common presenting symptom is a persistent sore throat. This symptom is frequently accompanied by ipsilateral otalgia, referred pain via the tympanic branch of the glossopharyngeal nerve. A vague sensation of throat irritation, restriction of tongue motion, hot potato voice, odynophagia, and bleeding may also be noted. Most patients, especially those with large lesions, are significantly malnourished. Many patients present with cervical adenopathy. Nodal metastases are found in 76% of patients with cancer of the base of the tongue and in 60% of patients with tonsillar cancer. Most of these nodes are palpable. Initial examination must include careful palpation of the tonsils and base of the tongue. Many small tumors are difficult to see but may be palpated easily. Many patients are asymptomatic until tumors are quite large and ulcerated, and consequently diagnosis is often made late in the course. Other patients are treated conservatively for incorrectly diagnosed lesions. All lesions should be evaluated by endoscopy under general anesthesia before treatment is chosen. CT and MRI are useful in determining tumor extension. T1 and T2 lesions are treated with radiotherapy. Combined therapy offers improved survival rates for most large lesions and is indicated when nodal metastasis is present. Complete resection, the jaw neck or commando procedure, is most commonly used to resect T3 and T4 lesions of the oropharynx. It involves a radical neck dissection and a partial mandibulectomy in conjunction with excision of the tumor. A tracheotomy is routine treatment. Occasionally, the larynx is spared after total glossectomy in young and otherwise healthy patients. A laryngectomy is performed when the tumor invades the preepiglottic space. The entire tongue base and both hypoglossal nerves are removed. The poor prognosis of oropharyngeal cancers is directly related to their late diagnosis. In tonsillar cancers, 5-year survival rates range from 63% for patients with T1 tumors to 21% for those with T4 disease. Patients with tumors of the base of the tongue have 5-year survival rates of 40 to 60% for T1 disease and 10 to 20% for T4 disease. A high incidence of late presentation is reflected in the large number of patients with T4 disease. For patients with tumors of the palatal arch, the 5-year survival rates range from 77% for T1 disease to 20% for T4 disease. The presence of nodal metastases reduces the 5-year survival rate significantly. For N0, the survival rate is 75%. For N1, 25%. There are many other malignancies of the head and neck with which physicians should be familiar. The most important of these are reviewed in Malignant Lesions of the Head and Neck, Part 2, which should be studied in conjunction with the information we have just presented.